Welcome, and thank you all for joining us at Small Number Reporting. I'm Dave Goodman. I'm the team lead for the Maternal Mortality Prevention team. How to effectively and responsibly work with small numbers has been a topic at MUM since the very first Maria user meeting, and we are very fortunate to have Jen Beauregard, the team's EPI section lead, as our presenter during this session. Jen joined CDC in 2017 as an EIS officer in CDC's Division of Nutrition, Physical Activity, and Obesity, where she focused on breastfeeding and early childhood nutrition. She received her PhD and MPH from Emory, where her work focused on preterm birth and social determinants of health. And it is now my pleasure to turn the screen over to Jen.
Hi, everyone. Thank you so much for joining us today. We're really excited to present our team's work and lessons from state and local MMRCs on analyzing and reporting data when there are small numbers. Today in this presentation, I'm going to start with a brief background and overview of the types of information products produced by MMRCs, and then talk about the guidelines that we employ in analyzing and reporting on small numbers. So I'm going to present some examples from our team's work and then the work of a few state MMRCs. I also want to acknowledge at the beginning of this presentation that I've drawn examples from publicly available MMRC reports, and I want to go ahead and thank those states from which I have drawn examples. Before I get into the more technical details of this presentation, I did want to pause for a moment and acknowledge the persons whose lives our work centers on. Each pregnancy-related death is a tragedy. Each year in the United States, about 700 persons die as a result of pregnancy complications. Pregnancy-related deaths are sentinel events reflecting population-level health. Sentinel events are conditions or deaths whose occurrence can be measured to assess the stability or change in health levels of a population. They are a signal flare or warning flag or tip of the iceberg, reflecting a cascade of less severe yet still important related events. It's estimated that for each pregnancy-related death, there are approximately 70 severe maternal morbidities. Targeting prevention of pregnancy-related deaths may be an efficient way to prevent not just future deaths, but also related adverse outcomes. With the level of information that MMRCs capture in their reviews, they can make effective recommendations and act on those recommendations to eliminate preventable maternal deaths, reduce emergency and acute events, and improve population-level maternal health. The causes of maternal mortality overlap with causes of severe maternal morbidity or near misses. By implementing actions to prevent future deaths, it's also likely that future morbidities will also be prevented. Now I want to highlight the variety of ways in which MMRCs use their data for action. Important uses of MMRC data include annual reports, topic-specific reports, more informal summaries of data for committee meetings, presentations by committee members, briefs, as well as process reports, such as data quality reports and process evaluations. Many MMRCs develop annual reports on pregnancy-associated or pregnancy-related deaths in their jurisdictions to share high-level summaries of information from committee reviews over a specified time period. MMRCs may be subject to legislative requirements to produce these reports. These annual reports, especially when looked at cumulatively, share important information on what MMRCs have learned about deaths in their jurisdictions, including causes of death, relatedness, preventability, and timing. They also are an important place to share the MMRC's recommended priorities for action to prevent future deaths. Content of these reports may include counts, rates or ratios, proportions of deaths broken down by key characteristics such as timing and preventability, a description of the review process, and recommendations. Topic-specific reports are developed when a depth of information around a specific topic is needed, for example, around deaths due to suicide, overdose, and homicide, as pictured here on the slide. These may be targeted to engage specific stakeholders in a priority area and to follow up with a report specifically focusing on that priority area. Content of these reports, similar to annual reports, may include counts, rates or ratios, and proportions. These reports may also include a synthesis of descriptive information with existing literature. And when presenting MMRC's recommendations, we'll focus on the recommendations specifically tied to the topic of interest. Summaries for the committee may be reports that share MMRC accomplishments and serve to engage committee members around the process and findings of their reviews. Content of these summaries may include the number of cases reviewed by the MMRC, the proportion determined to be related to pregnancy, and cover any findings that stand out for more detailed analysis and consideration. Presentations of MMRC data by committee members can serve to share and promote the committee's work, educate other committee members, and disseminate committee products and information. These presentations may include counts, rates or ratios, proportions, and qualitative analyses, as well as descriptions of committee recommendations and priorities. Briefs may be prepared when new issues are emerging in response to an ad hoc request or to alert or educate stakeholders broadly on maternal mortality reviews. Content of briefs might include evidence from MMRC reviews, synthesis with existing literature on the topic, targeted recommendations from analysis of the specific groups of deaths included in the brief, for example, specific causes of death, as well as targeted asks for programs, policies, funding, etc., on the basis of findings in the brief. Finally, it's important to use MMRC data for data quality and process evaluation reports in order to identify and address data issues early and build credibility for the review process, as well as the analyses and recommendations that result from the MMRC data. The content of these reports may include summaries of data, validations, and process measures. So now that we've gone through some various types of information products that MMRCs produce based on maternal mortality data, I want to walk through our team's considerations on small number analyses and reporting. I want to preface these slides by saying that the guidelines around presentations of small numbers are really subjective. These slides will focus on our team's practices, and I recognize that your institutions or organizations may have their own guidelines. There are two main considerations in presenting maternal mortality data or other data based on small numbers and sensitive data. First is the need to protect individuals from being identified by your reporting. Second is the importance of using your data regardless of the numbers. I want to state the caveat that it's very important to be aware of considerations around the reliability of estimates based on small numbers. I'll discuss our team's approach on both confidentiality and reliability in the next few slides. And I also provide some background on these issues, drawing on some materials on small number analyses that were developed by the Washington State Department of Health. A question that we hear from the field often is, what can we report on if we have small numbers? Our message in general is that even with small numbers, the information collected and produced by MMRCs is critically important and important to share. In presenting small numbers, one option is to aggregate data over multiple years as needed. Most analyses will be descriptive. If testing for statistical significance, we do recommend using exact statistical tests such as Fisher's exact test rather than procedures that assume large sample sizes. And finally, the really unique aspect of MMRC data is the detailed qualitative data available in committees' determinations of factors that contributed to the deaths and recommendations for actions to prevent future deaths. Often, analyses of maternal mortality data are similar to a case series, meaning that analyses will largely be internal comparisons among women who died. There is no perfect reference group with comparable data to the depth of information available to MMRCs on pregnancy-associated deaths. For example, the level of detail in case narratives and the development of specific contributing factors and recommendations, which would only be done in the case of a death. Some comparisons may be possible on a limited set of characteristics that are also available for a reference group. For example, race and ethnicity, age, insurance status, and other characteristics that might be available both for the people who died as well as a population-based data source such as birth certificates, PRAMS data, or other sources. For these comparisons, distributions among pregnancy-associated or related deaths might be compared with the populations of women of reproductive age or persons who had live births. While comparisons may be limited, it's important to keep in mind the richness of case data available for these case series analyses. MMRCs are population-based, collect comprehensive information about individual deaths, and have determinations made by an expert panel. One important consideration in analyzing and presenting on small numbers is reliability of the statistics produced from those data. In general, statistics such as rates, ratios, and percentages that are based on whole population counts of small populations are subject to random variation. If conducting a survey, these statistics would be subject to both random variation and sampling variation. Because they are based on small numbers, statistics may fluctuate from year to year due to small changes in numbers, even when differences may not be meaningful. Here in the slide is an example from the Alaska Maternal and Child Death Review. Each year in Alaska, there is a small number of pregnancy-associated deaths. Over 2008 to 2017, this number fluctuated between 5 and 15. If presenting only a pregnancy-associated mortality ratio based on these data, large fluctuations might be seen year to year. And it may mask the fact that the large fluctuations are driven by small changes in the number of deaths. Presenting the information in this way can allow the reader to see the raw information and accurately interpret the data. Now, this slide presents our own team's practices for reporting rates, ratios, and percentages. For rates and ratios, the main consideration is making sure that you do not produce an unstable rate or ratio. A measure of stability is the relative standard error. The cutoff for relative standard error is subjective, but we've decided that for our team's own reporting, not reporting a rate or ratio if the numerator is less than 8 strikes a reasonable balance between maximizing the use of available data and acceptable stability. And then for presenting percentages, our main consideration is making sure that we don't produce a misleading value. Where to place a cutoff for reporting a percentage is also a bit subjective, but we decided that for our team's reporting, not reporting a percent if the denominator is less than 10 strikes a reasonable balance between maximizing the use of available data and then acceptable interpretation. There is no common standard for data suppression for maintaining confidentiality. The risk of disclosure really depends on the size of the numerator. As they're developing tables, I liked this rule of thumb from the Washington State Department of Health that a breach of confidentiality can occur if knowing which category a person falls in on one margin, such as a row or column of the table, allows the table reader to ascertain which category the person falls in on the other margin. So for example, typically our tables that we report are one way, meaning they present characteristics of pregnancy-related deaths, but do not stratify by another variable. I wanted to walk through an example on this slide. The first table here presents a hypothetical distribution of pregnancy-associated deaths in a small population. And then the second table expands this by adding a stratification by pregnancy-relatedness. I wanted to show something here. So in the second table, among Hispanic persons with a pregnancy-associated death, all of the deaths were pregnancy-related and 0 were pregnancy-associated but not related. So if the identity of Hispanic persons with a pregnancy-associated deaths were known, then it would also be known with certainty that their deaths were determined to be pregnancy-related. So this is a type of situation that we would recommend that you look carefully at the presentation of the data and make sure that scenarios like this are not occurring in your presentation. And now I want to walk through our practices for reporting counts. Our main consideration here is making sure that we don't report information that identifies an individual. We think that it's valuable to report all counts greater than or equal to 0, as long as we're not reporting data in such a way that a count can be used to readily identify an individual. This could be useful for using your data when other statistics might be suppressed under your reporting rules. I do want to note that it's important in maternal mortality reporting to consider high-profile deaths where more people in the population may know characteristics of individual deaths when considering whether any information is identifiable. We have heard from several state MMRCs that they've encountered this in their work. It might be necessary to employ more restrictive suppression rules for reporting counts if you determine that reporting small number counts would present a risk of breaching confidentiality. I also want to talk about the importance of qualitative data analysis when detailed text data are available. Qualitative analysis provides an opportunity to understand the what, why, how, and where of phenomena beyond what can be counted. It doesn't depend on a large sample. Typically, qualitative analyses are based on having detailed data on a smaller sample of people. MMRCs have access to text data in case narratives, contributing factors, and recommendations developed by committees, as well as other abstractor notes fields in Maria. I do want to mention that it's important to maintain confidentiality in conducting and presenting qualitative data analyses by de-identifying text data. To summarize, concepts to embrace around small numbers is that small numbers themselves are not a threat to deciding action or priorities, although due to concerns that I've noted around confidentiality and reliability of statistics, reporting may be limited. MMRCs offer a unique, comprehensive, and high-quality source of data on pregnancy-associated deaths, and we encourage MMRCs to make full use of their data to drive action on prevention of future deaths. Now I want to show you an example of our own work based on small numbers, and this is an analysis conducted by my colleague, Susanna Trost. To date at CDC, our analyses of aggregate MMRC data have been based on data from 14 MMRCs that voluntarily shared their review data to us prior to ERASE-MM funding. This data contains information on 453 pregnancy-related deaths. Descriptive analyses of individual causes of death have each been based on a relatively small number of deaths, so we've employed our considerations on presenting small numbers when conducting and presenting these analyses. Shown here are slides from a presentation describing pregnancy-related suicide deaths in 14 states over 2008 to 2017. Of the 453 pregnancy-related deaths, 29 were suicide deaths. This number is small, but it's important to describe and learn from the characteristics of these deaths. Based on our cutoff of a denominator of 10 for presenting percentages, we presented the breakdown of these deaths by timing, preventability, and other factors. And I do want to make an extra note here. Of the 29 deaths, 21 had a preventability determination and 8 did not. Since there were 8 missing a preventability determination, we determined that it was okay by our own standards to report that 100% of the deaths that did have a preventability determination were determined to be preventable. So knowing that a pregnancy-related death was due to suicide does not actually tell you with certainty whether it was preventable, because of those 8 that were missing that information. When using data from MMRCs, an essential component is to use their qualitative data. In this presentation by Susanna, themes from MMRC recommendations were compiled and summarized. And then in other analyses, thematic or content analyses of recommendations have been performed, and recommendations have been compared and synthesized with existing literature. Our upcoming analyses also are starting to delve deeper into formal qualitative analyses of aggregate MMRC data. This is really a skill set that we are currently adding to our own toolbox as we provide qualitative trainings to MMRCs. Now I want to walk through some examples of small number analyses pulled from MMRC reports. As a side note, I would encourage all of you to take a look through other states' reports, many of which are available on the Review to Action website. We know that there's hesitance around describing population characteristics when there are small numbers. Our perspective and our practice within our own team is that it's valuable to report all counts, including zeros, so long as confidentiality is maintained. For preserving confidentiality, it may be important to avoid stratifying the population by multiple factors, such as breaking down the population of pregnancy-associated deaths by both demographic factors and pregnancy relatedness when numbers are very small. Many state MMRC reports include basic descriptive tables that describe the population of pregnancy-associated or pregnancy-related deaths according to key characteristics. On this slide is an example from Connecticut's recent report on pregnancy-associated deaths in 2015 to 2017. This table provides an overview of key characteristics among 32 pregnancy-associated deaths, including insurance status, educational attainment, race and ethnicity, and age. The numbers presented here are small, but the information is important to understand the population of pregnancy-associated deaths. I want to note that Connecticut combined data across 3 years for reporting here. The number of deaths per year ranged from 8 to 13. The total number of deaths included here remains small at 32. And then across these 3 years, 11 of the 32 were pregnancy related. So from CDC's perspective, the report could have also included a table presenting characteristics of just those 11 pregnancy related deaths, so long as there were no confidentiality concerns. Because many states experience small numbers of pregnancy-related deaths per year, MMRCs may choose to present the frequency or count of deaths by year instead of calculating a rate or ratio by year. In order to avoid instability of the rate or ratio and having fluctuations across years that could lead to misinterpretations. Presenting the raw numbers allows the reader to see that fluctuations are really driven by small changes in numbers. This information might be combined with presenting a summary pregnancy-related mortality ratio that aggregates information over multiple years, so that the audience could see both an estimate of that ratio plus the more granular information about each separate year. In the example here, Alaska presented the number of pregnancy-associated deaths for each year over the last 10 years, rather than calculating a ratio for each of the years separately. Another approach to address stability of rates and ratios is to combine data across multiple years. In the table and figure on this slide, Alaska and Connecticut combined data across multiple years to produce aggregated pregnancy-associated and pregnancy-related mortality ratios. In the example from Connecticut, they first presented the raw counts by single years, and then computed pregnancy-associated and pregnancy-related mortality ratios, combining data across 3 years. In the previous slide, I showed how Alaska presented raw counts of pregnancy-associated deaths for single years across 2008 to 2017. And here on this slide is a figure from the same report in which they combined data from 2012 to 2017 to produce an aggregated pregnancy-related mortality ratio. Combining data across the multiple years allows for a more stable ratio for comparisons, such as the comparison here made to the national ratio. When analyzing small numbers data, such as Maternal Mortality Review Committee data, it's important to maximize the use of qualitative data that are available. MMRCs abstract and produce rich, detailed data across case narratives, contributing factors to the deaths, and recommendations for actions to prevent future deaths. Many MMRC reports include a presentation of the recommendations of the committee. In this example from a recent Illinois report, the report summarizes committee recommendations at various levels. Pictured here are recommendations at the patient, family, provider, and facility levels, as well as for health insurance plans and managed care organizations, and for the state of Illinois. We are working towards building capacity in your MMRCs for conducting qualitative analyses, so we hope that presentations of qualitative data will continue to evolve. And then finally, when presenting data based on small numbers, it's helpful to clearly articulate any data suppression rules used in presenting your analyses, as Arizona included in their recent report shown here on this slide. For Healthy People 2010, a document, which is pictured here on the slide, was developed to provide the specific data suppression criteria for 22 major data systems used to track Healthy People 2010 objectives. This document is really informative in providing examples of rules used across different major data systems that are still in existence, but I do want to note that this document is very outdated and hasn't been updated for Healthy People 2020 or 2030. If interested in the current data suppression rules for any data system, that's listed in the document, you would need to look into the current documentation of that system. The general approach across data systems was to suppress data if they did not meet criteria for statistical reliability, data quality, and confidentiality. Common reasons for suppressing data were that the number of events was too small to produce reliable estimates. The number of events was too small to preserve confidentiality. The sample design did not produce representative estimates for a particular group, or there was high missing or unknown for particular items. And then, as I noted earlier, the Washington State Department of Health has a comprehensive resource on reporting data with small numbers. It provides a really excellent summary of statistical and confidentiality considerations when working with small numbers. I just want to close with some summary points around our perspectives on small number reporting. We really encourage and we practice ourselves embracing and maximizing the use of all available data for informing maternal mortality prevention. In reporting on small numbers, it's essential to protect the confidentiality of highly sensitive maternal mortality data and necessary to evaluate each data presentation to ensure that confidentiality is maintained. And then finally, it's important to be aware of statistical reliability concerns in small number analyses and to employ suppression rules and use alternate methods of data presentation when necessary. Thank you so much for the opportunity to talk with you all today. And Susanna Trost and I will be happy to answer any questions. And I see some are coming in the chat already.
Thank you so much, Jen, for that great presentation. I'll go ahead and start going through some of the questions that we're receiving in the chat box, but feel free to continue adding your questions. And then also any questions we don't have time to address today, we will definitely bring back to the team and continue to discuss during future analyst office hours as well. So please feel free to put any questions that have come up in the chat box. The first question, Jen, is do you have advice on how to explain the limitations and nuances related to small numbers to the audience reading these types of reports?
Sure, that's a great question. In general, my advice would be to, to present these two ideas of reliability of estimates and confidentiality around small numbers, and to do that in a really user-friendly way. So even in this presentation, I'm not relying really on our statistical considerations on determining when we think that numbers are reliable. I think there are user-friendly ways of explaining that when results are based on small numbers, you may see fluctuations, and it may be driven by very small changes in the numbers and not actually meaningful differences. And so I think this is actually something that we could address in terms of MMRC analyst resources and providing some sort of template language that you all could use in reports and then use in messaging those reports.
And I think on the theme of conveying some of these findings to different audiences and thinking through how best to reporting, necessarily around small numbers, but just thinking about how you can best communicate what your pregnancy-related mortality ratio means. We have seen some states where they actually put a sample interpretation within the report to help communicate what this ratio means and how it may compare to some other statistics that may be publicly available that people are seeing related to maternal mortality. Another question we have in the chat is, in our first year report for 2018, we were able to calculate a PRMR. However, in the second year, we had 5 deaths. Would you recommend doing a combined PRMR between 2018 and 2019 for the 2019 report? And should we explain why we combined years?
So per our guidance for our own team, we would not report a ratio if the numerator were less than 8. We do understand that other organizations have different practices around this. And so really, I would say that it would ultimately be based on what your organization feels comfortable with reporting in terms of the reliability of that estimate. If that were something that CDC were reporting, we would likely combine that with the previous year. So then you would report an overall 2018 to 2019 PRMR. I would also consider, as I presented in the example from Alaska, I think it's very informative to be able to present the numbers by year and then report the summary estimate. So I might consider a combined approach that really lays out all the information.
And what methods did CDC use to arrive at the cutoffs of less than 8 as the numerator and less than 10 as the denominator? Could you explain a little bit more about that process in deciding the cutoff points?
Sure. Actually, that actually predates me joining the team, but I can tell you about our considerations around that. So I can't tell you the nitty-gritty of the exact details of what we looked into. But for the cutoff of the 8 numerators, so this one is really based around the reliability of the estimate. And when we talk about that, one of the measures that we use is the relative standard error. So that would be the relative proportion that the standard error represents of the estimate itself. And so there are methods that I'd be happy to share in any follow-up for how to calculate that given a measure. So there are cutoffs out there for the relative standard error that vary. I think most of what I see is sort of around 25 to 30%. If your standard error is more than 25 to 30% of your estimate, you may want to reconsider presenting that due to reliability concerns. And so what we did was look at how different numerators played into this and what the relative standard errors looked like for different numerators when looking at PRMRs. And then we made a judgment call on how to, on where to draw the line, and what we landed on was 8. And then in terms of the percentages, here we were looking at really presenting misleading percentages. So what we determined was that presenting a percentage of less than based on a denominator of less than 10 really was misleading in terms of the interpretation of the percentage. So if you're talking about less than 10, then an individual in that population would make up more than 10% of the total. And so really small fluctuations would make a large difference. And so again, this was really a judgment call in terms of where we felt comfortable with drawing that line.
And we will have a hard stop at 2, so I just want to touch on a few other short questions, and then again, we are happy to continue these discussions, so feel free to add them in the chat or email us as follow-up after today's session, and we can touch on them at office hours. There's also a question about slides being available. We will share them after today's presentation and make them available to you all. Let's see if there's a quick one we could touch on before 1 minute. Let's see. What are the thoughts about using as a comparison group the number of births versus number of pregnancies within a state?
Sure, that's a great question. I don't have a great answer for that right now. That is actually something that we are looking into as a team. And so I would love to keep you all posted on that. And I would love to hear from you all as you explore that question.
And we are out of time for today's session, but thank you all for joining us, and we look forward to continuing these conversations.